Now, before starting the next part of my presentation, I have some questions to answer, and I will start from the last one. Could we attach elastic from the face mask to the hooks on the bands of the deciduous molars? No, it's better to add the hooks as I showed you before, because when you attach it to the bands, it is a little bit more difficult for the kids, and it doesn't work so well. No, better to add the hooks. With elastics, you use how much force? I use the more force they can. If I don't give any rule to the kids, the more you can. Usually they use the mask at night, and the force is around 2.5–300 grams. But somebody is able to use heavier elastics, and even if it is rare, it may work better. So there are no rules. The more you can, more hours and more elastic you can. Which elastics you use? The more they can. I give the orthopedic elastics. I start with a lighter elastic, and then I give some stronger elastic. They can place 1 or 2 elastics, what they want. The more they can. There is no limit. We don't have a rule. So the more they can. Do you prescribe to patient myotherapy? Yes, only for the lips, not for the tongue, never. It's very rare that I send the kids, I refer the kids to a speech therapist for the tongue. It is very difficult. In my life, I met maybe 1–2 patients who really learn how to use the tongue with a speech therapy. What I think is that if they stay with the lips closed, the tongue is not able to create an open bite. So, in my opinion, the lips are more important than the tongue. With the lips closed, the tongue is not dangerous. So, it is very rare that I ask the patient to go to a speech therapist to teach to learn how to use the tongue. Can you tell the exact instruction that you give to the patient with RPE? Adaptation, hygiene. What I stress very much with the parents is the hygiene. I want they clean very well, especially if you have the acrylic pads around the pads. I give my mobile telephone number to all the patients with RPE, because if they have a decubit below the pads, I must be available also on Sunday. It's very rare, but I'm scared about the poor hygiene. This is the most scaring possibility. Only if you use a HAS appliance with the acrylics. I give them written instruction. Yes, written instruction, because they must. I write the more thing I can to the patient. I give a lot of written I write everything, treatment plan, everything, because I think that instruction must be given before treatment, the more we can. And yes, they have an instruction. I email an instruction to the parents when they start screwing with a rapid palatal expander, where it's written, call me whatever happens. If it seems that the nose is widening, stop activating, call me, clean very well. And if you have nose bleeding, stop activating and call me. Yes, I give written instruction. If the rapid palatal expander is activated 2 times a day, then at what time should it be done? Well, when they want. Usually they do it in the evening, but they can do it when they want, more or less every 24 hours. We fix stud in a certain location or in any position of a certain design. Now, usually I take a CBCT to plan where to place the studs. Usually are on the line between the first primary molars, and the screw we use is a 8mm screw. We place the screw without a guide, without a dime, because Dr. Patrizia Lucchi, who plays it, is very expert. But if you have a dime and a guide, it would be much useful, of course. 8mm long, it is enough. Have you ever used brachial appliance? No, never. What do you think about Derisch-Schweiler appliance? I don't know it. I think it's a good appliance, but I don't know it. Okay, nothing more. Sorry, another question. Do you recommend to extract adenoids? I already answered. Yes, if the ENT specialist asks to think that the adenoids must be removed, I agree. Yes. So let's start our 6th part of the course, skeletal discrepancy. We will talk about class 2 and vertical discrepancy. And this is a skeletal class 2, of course. She is very severe. Severe class 2 malocclusion from a skeletal point of view. Dentally is a class 1. Here you see the narrow palate, a little bit more on the right part, even if the crossbite is on the left. A narrow palate, unilateral posterior crossbite, a little bit of crowding for the lateral incisor, not so much because she has small teeth. The class 2 skeletal discrepancy is 6 degrees, INB, very evident, as well as the vertical skeletal pattern. So this is a skeletal class 2 open bite, severe class 2 open bite skeletal discrepancy. The Steiner cephalometric assessment shows the same, a very hyperdivergent class 2 skeletal malocclusion. Of course, the maxilla was narrow. I expanded the maxilla in order to fix the crossbite and in order to create adequate space for the lateral incisor. The appliance was bonded and banded on the deciduous teeth, and after the expansion, the midline is corrected because the mandibular shift fixed spontaneously in a few weeks. This is a mistake I did. I removed, no, sorry, this is not a mistake. Once again, I used a 9mm screw. I expanded the whole screw, but it was not enough to create adequate space for the lateral incisors. So at a certain point, I realized that the upper right incisor, lateral incisor, had not adequate space, and I decided to do a second RPE. So RPE 1 is this, no space for the upper right lateral incisor. She improved, not so much in the face. She still is a vertical grower, a lot of difficulties in keeping the lips closed. And here is the reason why I placed a second expander. I wanted more space for the lateral incisor. This is the second expander. I created adequate space for the lateral incisor, but I I created a scissor bite in the back segment, and this is not so welcome, because with the scissor bite the occlusal stability was poor, and I had a COCR discrepancy, a mandibular shift. What I did, I placed a little bit of a little resin resin bite block in order to to stabilize the condyle and to stabilize the midline. Very little, without increasing the vertical dimension. She is an open bite, and I want to increase the vertical dimension. And I stabilized the mandible. It would have been much better to grind occlusally the primary molars, but I didn't do it. So from a vertical point of view, the resin bite block are not effective. They just keep the mandible in the middle, but they don't act positively on the vertical dimension. So I fixed both the scissor bite and the mandibular position with the acrylics, with the resin bite block. Before the removal of the palatal expander, you see that the permanent molars are closing quite well, and still I have an open bite on the front teeth, on the incisors. I removed the expander. This is the end of early treatment, and now you see, here is June 2006. I removed the appliance in March 2006. After 3 months, you see that the open bite is improving. Now I have an open overbite which is within the normal limits. The molars, the permanent molars, are settling down very well, and she still has a lot of difficulties in keeping the lips closed. Another couple of years, here is 2008, 2 years out of retention. I didn't do anything else than picture to this patient. And you see a good occlusion. Still, she is in difficulty in keeping the lips closed, but a little bit less. So 2 years out of retention, still he is hyperdivergent, but the open bite improved spontaneously. And spontaneous improvement of the open bite is something I see in the vast majority of my patients in mixed dentition, without any type of myofunctional therapy on the tongue, just working on the lips. This is the profile. Interestingly, it is a little bit better, but still a class 2 malocclusion. I took another head plate and I noticed that the A and B angle was better. Now is only 4 degrees. And so the pattern of growth is good. I understood that she was growing better. So 2 years out of retention after the palatal expansion, I did a superimposition. I did a new head plate, a superimposition, and I was very surprised in seeing that this patient not only is growing in a good direction, in a counterclockwise direction, but she is growing in a counterclockwise direction very much. She is not a good grower. She is a beautifully grower. So I was very happy, and I decided not to do anything else than checking her during growth. 2 more years out of retention, 4 years out of retention. Very stable, no need of second phase. 5 years out of retention. No phase 2 profile is improving. The spontaneous correction of the open bite is stable. And excuse me, this is a patient I don't like to show to you. So what I want to emphasize with you is that if you are in front of a good grower, for sure you don't need any specific therapy to close the bite and to improve the facial growth. It is only a matter of genetics, is only a matter of DNA. It is very interesting that you see this patient because it is not frequent to see these very good growers. But once again, this is to emphasize the fact that it's not the appliance who makes the patient growing well, it's the genetics. I didn't do nothing else than a rapid palatal expander in this patient, and she grew so well. Look at the superimposition. It is unbelievable. Look at the chin. I met some patient during my career, orthodontic career, who grew like this, but they are very rare. The most important thing is that you become able to recognize them immediately. And if you recognize them during growth, everything will be easier when you talk to the parents, when you plan how to do the second phase, when you plan what to do in the future. So a good grower can happen, and of course, in this case, the favorable growth fixed everything without touching permanent teeth and without cooperation. This is a similar patient, a hyperdivergent class 2 skeletal malocclusion. Also the teeth are in class 2 on the right, so he is a class 2 subdivision, severe vertical hyperdivergency. So the crowding is evident in the upper jaw. The crossbite, the unilateral crossbite is evident on the right side. But the lip incompetence is the main problem to me, because the profile is a little bit concerning. I don't like the profile. In the family, there are some long faces, and so with after having taken the ear plate and after having looked at the assessment, I guess that this patient could grow in a counterclockwise direction, which means that he is at the beginning a severe hyperdivergent patient, but probably growth will help me. So the only thing I have to do is not to hamper favorable growth. The only thing I have to do is not to keep the lower incisor proclined, because if you keep the lower incisor proclined with a lingual arch, you will hamper the possibility of the lower incisor to move back and to let him grow in a counterclockwise favorable growth. So lower arch, once again, is the most important factor to be considered. And I have in my treatment plan is written that I should tip the lower incisor lingually a little bit in order to allow the mandible to grow in a counterclockwise direction, in the direction of the nose. This is what I need to confirm during growth, but this is what I was thinking, looking at the family, looking at the cephalometric assessment. First of all, in this patient, with a Jarabach analysis, I look at the sellar angle, which is normal, and the length of the ramus, which is almost normal. and also the gonial angle is not so big. So I think it will be a good grower. The thickness of the symphysis is another sign. But the skeletal discrepancy at the beginning is very high, and so we have to confirm that he is a good grower, and I will do it in a couple of years after having removed the rapid palatal expander. This is a main point. So the crowding on the of the left upper incisors is very evident. The crossbite, of course, this is the expander, 13 millimeter screw, 13 millimeter screw, Haas type, to create space for the lateral incisor to fix the unilateral crossbite, perhaps to improve the class 2 subdivision. Actually, the class 2 subdivision improved, but is not correct. The molars still are in class 2 on the right. The midline still is a little bit deviated to the right. The class 2 subdivision can be corrected by placing the midline in a hyper correction position, a little bit 1-2 millimeters to the left. This is the wax I use to keep the mandible where I want while I'm doing the RBB. Here you see the resin bite blocks. This is the wax you need to build up the resin bite blocks directly in the mouth. And here, after the resin bite block on the right and on the left, you see the molars are almost in class 1. These are the very small, very little resin bite block. Of course, now I have a COCR discrepancy because by moving the midline, by correcting the midline, I will pull the right condyle a little bit out of the fossa. This is how he is growing from October 2007 until January, only 3 months. You see the settling down of the right molars, not perfect on the left. 6 more months, and now the occlusion is good on the right and also on the left. The molars are free to move and settle down in occlusion. After 1 year, the midline relapsed a little bit, but the molar and the canines on the right, where there was the class 2 malocclusion, are well in occlusion, in a correct occlusion. I removed the appliance 2 years after the rapid activation, so the screws stayed in the mouth 2 years until the full eruption of the lateral incisor. Once again, this is the time when you can remove the screw, not before, 2 years. And I checked the lips, I checked the profile, I checked the aesthetics of the face. So I was successful from an occlusal point of view. Even if the midline is not perfect, the class 2 malocclusion was corrected. Now I have to take care of the facial growth and of the eruption of the canines and premolars. So I take the picture of the face, I check the lip incompetence, I take another head plate. The third molars are now developing in the lower jaw. Still, there is a slight protrusion of the lower incisor, while the upper incisor are very well positioned. I now want to check, and what I need to have confirmed that he is growing in a counterclockwise direction. This is fundamental to me to decide how to proceed on the treatment. What I need is a well-done superimposition. Well-done means following the teaching of Arne Bjork. We superimpose the two tracing on the anterior cranial base, the anterior part of the cella, the anterior anatomical structures, and we see what happened with the jaws. I noticed that he is a vertical grower, but there is also a sagittal improvement. So he is growing not so much in a favorable direction, in a counterclockwise direction. The direction of growth is not very favorable like in the patient before, but is not growing only vertically. What is the difference? The second difference between this patient and the patient before. The patient before was a girl. The girl improved less because they don't grow so long as the males. The males are growing for many years, and the more they grow, the longer they grow, and the more they will improve if the growth is favorable. So he is improving not so much, but he is a male. Probably he will grow until 16 years of age in a direction, I would say, not so vertical. So there is no crowding in the lower jaw, no crowding at all. But if I want to allow the mandible growing in a good direction, I must allow the lower incisor to go back a little bit. So I decided to extract the molars, even if there was no crowding at all in the lower jaw, for extraction, in order to allow the mandible in growing in the direction of the nose the better we can. In other words, to allow the mandible growing well, I need to allow the incisors to go back. What is important now? That he works with the lips. We want the lips closed. Lips closed is much more important than the posture of the tongue. So exercises to strengthen the lips, whatever you want, but whatever they do to keep the lips closed is very welcome. And here is what happens 1 year after the extraction. The upper premolars are erupting, the holes in the lower jaw still are evident. This is after 1 year after the serial extraction. This is after 2 years. This is after 3 years after the extraction. 3 years after the extraction, 5 years after the rapid palatal expansion. Now the canines are in class 1, and there is no space, no diastemas between the upper premolars and the upper canine. And you start seeing that the patient is not anymore in that difficulty in keeping the lips closed. He can keep the lips closed a little bit more comfortably now. And here is 5 years after the extraction. And here you see that he can close the lips, he can stay with the relaxed mental muscles. You can see a little bit of definition of the soft tissue here and on the chin. And the extraction were made 5 years before. Growth is favorable, but not so much. Here is 7 years after the extraction. And you see that in the lower jaw, the spaces are much less. They are not closed, but they are much less. Now he is 18 years of age. He is at the end of the peak of growth, and the improvement is very evident cephalometrically. Now the class 2, the skeletal class 2 disappeared. Now we have the lower incisors on the same line than the chin, on the same vertical line, a little bit protruded, but only 2-3 millimeters. And now we can keep the lips much more closed. So the early stage of treatment was very effective in allowing him to grow at the best in a counterclockwise direction, in the peak of growth a little bit more than before. Black before treatment, blue after the rapid palatal expansion, red when he was 18 years of age. The impressive improvement in the soft tissue is due to the normal growth, to the genetic inheritance of this patient, and not for sure not to the expander, not to the extraction. The extraction were necessary to achieve a good to allow the teeth wrapped aligned and not crowded. So during growth, I noticed not only an improvement of the face, impressive in the peak of growth, but the absence of crowding. It is very easy to guess that if I wouldn't have extracted the premolar, I would have a little bit of crowding of the upper jaw and even more in the lower jaw. The serial extraction are very effective to prevent the crowding of the lower incisor. They go back. They must go back because the mandible wants to grow properly, but they go back being straight, not being crowded. So the reason of the improvement of the face is not the appliance, is not the extraction, is not the palatal expander. We don't know it, at least. Could be, but we don't know it. Maybe. But the reason why I decided to extract the teeth is that at the end of growth, I want to have aligned incisors and not crowded incisors, especially in the lower jaw. It means, in other words, that if you don't treat this patient during growth, they will grow good, in a good direction, in a counterclockwise direction, maybe a little bit less because the lower incisors are touching. But of course, at the end of growth, you will have crowded incisors. If you want to prevent the crowding, you must do extraction, because with the extraction, you allow the mandible to grow in a good way, and you allow the incisors to go back aligned. If you want to prevent the crowding with a lingual arch, of course, it will be a disaster, because the counterclockwise mandibular growth, which is written in his genetic code, will never be able to happen, because the proclined incisor with the lingual arch behind will never allow the mandible to grow like this, and the patient will grow more vertically. So what is important? To let these long faces grow without nothing in the mouth. No appliances. Whatever you place in the mouth, it will hamper this counterclockwise pattern of growth. Extraction is the best way to prevent crowding, and this is what the patient wants. They don't want crowded incisors. I want an improvement in the occlusion, in the position of in the profile, but they want straight front teeth. This is the dental velar compensation during a favorable counterclockwise growth of the mandible. Dental velar compensation means that during growth the incisor rotates back while the molars come forward. Once again, this is a beautiful orthodontic treatment, in my opinion. This is the way we want to treat our patient, our kids, our sons, our daughters, without creating any stress with appliances, without touching permanent teeth. Just let they grow at the best. This is a real orthopedic, beautiful treatment. Second phase is just a cosmetic treatment. He can do it, he cannot do it. I'm not so convinced that the second phase is really necessary in these patients. Of course, with a second phase of treatment, we can beautifully display from an aesthetic point of view the anterior teeth. We can close the spaces because flatten the curve of Spee. And here you understand what I was telling to you yesterday. These are the patients who during life are the more stable, talking about crowding. These are the patients who, when they are 50 years of age, they are aligned. They have aligned incisors for extraction patients. I'm sure that when this patient will be 40, the holes between the lower canine and premolars will be totally closed. When he will be 50, probably there is a little bit of crowding on the incisor, 1-2 millimeters, but I will see. Okay, let's talk about class 2. Class 2, protruded teeth. In the past, I grew up hoping that I am able to stimulate mandibular growth, even more if I do it with an early treatment. What did I learn in these last 30 years? I learned from the literature. There is a wide literature about mandibular growth enhance mandibular growth stimulation. We know from the literature that we can pull the mandible the more we can, but there is no extra mandibular growth with an early treatment. Early treatment works like a one-phase treatment during adolescence. No extra growth of the mandible. We know that early treatment is not able to stimulate more the mandibular growth. We know that two-phase treatment or one-phase treatment during adolescence has the same effect on the mandibular stimulation of the mandibular growth. We know that the only reason to do an early treatment in this class 2 division 1 patient is our wish to reduce the risk of having traumatic injuries on the protruded front teeth. And this is a good reason to start treatment before, because if they have an injury on the incisors, it will be a big problem for the whole life. So the only thing I ask to the patient when I see a class 2 division 1 for a first consultation is, how many times did you hurt the upper incisor? How many times did you had a traumatic injury on the incisors? And if they say, I had several traumatic injury on the incisor, I advise to do an early treatment. If they answer, no, I never had a traumatic injury on the incisor, I have protruded incisor, but never had a traumatic injury, I advise them to wait the end of the transition. What about the profile? The profile means bones, doesn't mean protruded incisor. The profile is the soft tissue, the position of the chin. What about the profile? What did we learn in the last 30 years about the possibility to improve the profile? We learned how to use different appliances, functional appliances, headgear activators, only headgear. We learn that the extraoral traction could be a good appliance, but also the functional appliances are very good. I treated these two patients many years ago. They were more or less the same at the beginning. Long faces, class 2, division 1 patient. A great difficulty in keeping the lips closed. Open lips. I treated the girl with a vertical high pull activator. So vertical high pull and activator to fix the class 2. Now she is in class 1 on the molars, on the canine. And then I treated the boy with a headgear, cervical headgear on the chin. So more or less the same. I didn't do the second phase in the boy. Here is at the end of the transition. I did a short second phase at the girl. Both were treated without extraction. And at the end of the transition, both shows a very nice, very good occlusion, a full class 1 occlusion. In the girl, I did a little second phase. In the male, no. I used the cervical low pull on the boy and high pull in the girl. This is the boy at the end of growth. This is the girl at the end of growth. Of course, I like much more the boy, and you too, I guess. This is the early treatment stage, white to red. I used a cervical headgear. So I extruded the molars, the upper molars. So I created something which is not so welcome. I did a mistake, because when you extrude the molar, you create a clockwise rotation of the mandible, which is not very welcome in the class 2 malocclusion. Nevertheless, he was a good grower, and at the end of growth, look, everything is fantastic. If the genes are these, you can use also a cervical headgear. You can also do a wrong treatment. Everything is fixed by the normal growth, because normal growth is favorable. From red to green, I didn't do anything else than pictures. This is the face at the end of growth, beautiful profile, not because of the appliances, because of the normal growth. In the girl, I did a perfect treatment because I used the high pull activator. So instead of extruding the molar, I intruded, let's say, the molar. I tried to prevent extrusion of the molars, so the mandible can grow in a counterclockwise direction. This is very good. I presented this case to the European Board of Orthodontics, and they told me very good, very good. Class 2 Division 1 non-extraction case. But she was a vertical grower. This is written in the DNA. A good appliance cannot change this direction of growth. And so, at the end of treatment, there is not an improvement of the profile, there is a worsening of the profile. The normal vertical growth is not able to improve the profile, of course. And my treatment, a good treatment, which of course moved back a little bit the incisor, created an opening of the nasal labial angle. She doesn't care, but it's not an improvement of the profile, it's a worsening of the profile. I didn't do anything else than an expansion in the patient on the right, you will remember it. I strived with a lot of appliances, and I did a very good treatment in the patient of the left. 3 years of treatment, everything was perfect. But this is a good grower, the other one is a bad grower. If you have a good grower, everything goes itself. Very rare to see a good grower like this. Very rare to see a bad grower like the other girl. So remember this case, because you must recognize them the sooner you can. So let's talk a little bit about what we can do on the bones in order to fix a class 2 skeletal malocclusion. Everything is well described in the literature of the past century, 1980, 1990, until the end of the past century. Lyle Johnston wrote everything in 2 pages in this beautiful article published in 2002. You just have to read 2 pages to have very clear in mind what you do when you place a functional appliance, when you place an headgear on this class 2 skeletal malocclusion. But I will do a summary for you now. And believe me, this is the truth. The other are biased opinions. You think you do something, but it's not the appliance, it's something else. What we know is that, of course, we decide to use functional appliances to stimulate mandibular growth. This is the reason why everybody of us uses functional appliances. Not me, of course, because you want to stimulate mandibular growth. But if you look at the literature, if you look at the numbers, if you look at the patient treated by the best orthodontist in the world, you will understand, you will learn that what you can stimulate is, once again, 2 millimeters, maybe 3. 2-3 millimeters is nothing, you cannot see it. On the other hand, unfortunately, we know from the long-term studies that even if you use a functional appliance, you move back the maxilla. Because to stimulate the mandibular growth, you need to use the maxilla. Whatever you place as a functional appliance, there is a double movement, the maxilla forward, the maxilla back, the mandible forward. Doesn't exist a stimulator of the mandible which is anchoring on the chest or on the wall in front of you. You always, to stimulate the mandilla, are using the maxilla. So what happens when you stimulate mandibular growth? That you move the maxilla back. This is very evident in the literature. All the functional appliances move the maxilla back. Even more, there is a growing body of evidence. It was a growing body of evidence in the 2000s, now even more, that the final result when you use a headgear is not distinguishable, is the same, is equal to the result you obtain when you use a functional appliance. It means that if you use a headgear or if you use a functional appliance, you do the same on the bones. The maxilla goes back and the mandible is stimulated 2 millimeters to grow. In other words, and this is the truth, an extraoral extraction works more or less from a skeletal point of view. I'm talking about the bones, the jaws, point A, point B. I'm not talking about the teeth. They are working the same. Point A, maxilla goes back, and point B, mandible, can be stimulated a couple of millimeters, which is nothing. So look at this class 2 malocclusion, very severe. incompetent lips, interposition of the lower lip, a disaster. So he has protruded incisor. The most important appliance are the closed lip. So in order to do the best, I not only plan to fix the incisor protrusion, we were scared about the traumatic injury, but I want to improve the lip strength. The Frankel appliance, in my opinion, was at that time one of the best appliances to do all these things. Improve the strength of the lips, promote lip competence, push back the incisor, and this is what I did in this patient. I did an functional appliance for the lips more than for the bones, and of course the appliance will be very effective for the teeth, for the protrusion of the teeth. Then the Frankel appliance, we know from the literature, create a little bit of transverse expansion. But the most important thing, the goal of treatment, was also to fix the overjet. First priority, prevent traumatic injury. Thus means that I want to move back the incisor, and this will allow the lips to stay much more closed, even more if you augment the strength of the lips. So this is the overjet correction in 1 year. He was a very good cooperator, he complied very much. Look at the lips, very, very relaxed, very closed, and I was very happy. The overjet was corrected. What about the bones? What about the bones? Bones is the jaws, maxilla and mandible. The bones, now we'll see them, are still in class 2 probably. Okay, here is the protrusion, the correction of the protrusion, which is the main goal of treatment in order to reduce the risk of traumatic injury. These are the bones. Of course, you need numbers. These are the numbers. A and B decreased 1 degree, nothing. Still is a class 2 malocclusion. The overjet is fixed. I cannot stimulate the mandible more than this. The orthopedic effect is very little, almost nothing. But the Frankel appliance is one of the best appliances to stimulate mandibular length. But if in 1 year the overjet is fixed, then you cannot stimulate anymore. The mandible was probably is longer, a couple of millimeters, but I don't see it. So functional appliances are very effective in stimulating the mandibular length 1 to maybe 3 millimeters if your treatment lasts more than 2 years. But we don't see it. We don't see it. The maxilla will not grow forward. As you see on the superimposition, the maxilla stays sagittally where it was before. And this is the very predictable effect of any functional appliance you use. So remember, functional appliance, move back the maxilla. Here is the occlusion at the end of the first stage of the transition. The lips were very closed, very strong. So after a few years, after the transition, when he was 15, not only the protrusion is stable, I have a class 2 division 2. I have a deep bite. I have a retroinclination of the upper incisor. But we are talking about the bones. Look at the bones. Do you see a great improvement? Of course, it is impossible to stimulate more than this because the overjet is correct. I don't see a lot of improvement in the profile. This is when he is 17. The upper incisor are retroclined. The pattern of growth is beautiful, is growing in a very good direction, in a counterclockwise direction. But the skeletal discrepancy was huge at the beginning, even if he is growing well, even if I did my treatment in a good way, even if I did all the stimulation of mandibular growth I can do, still is a class 2 malocclusion. And of course, he's a very nice boy. He's very happy like this. He doesn't want any phase 2. And I agree with him. This is the mandibular stimulation plus normal growth. The skeletal effects are significant at the maxillary level. Fortunately, the treatment was very short. Otherwise, the maxilla would have been pushed back even more. Maxillary retrusion is due, of course, mainly to the inheritance, to the genetic code, but treatment for sure gave a little bit more of maxillary displacement to the back. And if the maxilla is back, the palate is narrow. If the mandible is back and you are in a good occlusion, it means that you pushed back the maxilla. Of course, the smile is very narrow. So the skeletal effects are very evident in the maxilla, not only in the profile, but also transversally. Narrow smile. Look at this other patient, another class 2 division 1 patient. He was at the beginning, in the first transitional period, 6 years and a half, a full class 2 skeletal malocclusion, 8 degrees, A and B was 8, full class 2, the incisors are the primary incisors. We knew at the time, 1996, that any appliance we can use to correct the class 2 division 1 malocclusion works mostly on the teeth, on the dental volar component. The bones can be moved, as in the patient before, just a little bit, couple of millimeters below if you stimulate, and 2, 3, 4 millimeters back in the maxilla. The Herbst, at that time, Herbst was the functional appliance who was able to stimulate the mandible at the best. So Herbst was the appliance which created the possibility to stimulate the mandible at the best, 2 millimeters every year. So I built up a Herbst appliance, a rapid palatal expander with a Herbst protraction arms. And when the appliance was in the mouth, the kid was in class 1, of course, with a protruded mandible, protruded condyles, and a class 1 occlusion. 1 year, less than 1 year of treatment. I removed the arms and the canine are in class 1. I expanded the maxilla. Now the maxilla is very nice, very good, displaced. And I am in class 1. 1 year of treatment. Fantastic. And this was the appliance which, more than all the other appliances, was able to stimulate mandibular growth. So before early treatment, 10 months after early treatment, very stable, no retention at all. End of the transition, 6 years after the end of early treatment, no retention at all. Very stable in class 1. It is fantastic. a short treatment, less than 1 year, no cooperation, to get the maximum stimulation of the mandibular growth, and no phase 2, nothing, no phase 2. Why do you see a little bit of crowding in the lower incisors? 14 years after treatment, after early treatment. Now you know it. You have crowding in the lower incisor because he was a good grower. I did a treatment without extraction, so the cost you have to pay to allow the mandible growth in a good way is to allow the incisor to go back. They have to become crowded. If you want, they go back in order to allow the mandible to grow forward. And this is the reason why there is a crowding in the lower jaw 14 years after treatment. But we are talking about the bones. We are interested in the bones. No retention, very interesting from an orthodontic point of view. We must allow the lower incisor to become crowded lingually. Because if you place a lingual arch, you do a retention, you will push the mandible in growing only down. No phase 2, I didn't touch permanent teeth at all. I didn't touch permanent teeth at all, nothing. What we knew from the literature and what happened in this patient is that the Herbst appliance stimulate mandibular length, 2, 3, 4 millimeters. There is a supplementary elongation in the total mandibular length. We know that the coefficient of mandibular stimulation is 0.3 millimeters per month, but since treatment didn't last more than 10 months, of course, is only 3 millimeters. After 10 months, the overjet was correct. You have to stop treatment. You cannot stimulate for 5 years because you cannot create a class 3. So it is always 3-4 millimeter, very predictably. But the Herbst appliance also will move back the maxilla, and here you see very well the A point going back. And here you see the profile. If you look at the profile very well, you will notice not the stimulation of the mandibular length. You will not notice, the longer chin. You will notice the maxillary displacement to the back, the opening of the nasolabial angle. So, for sure, I stimulated the mandible, but the cost I had to pay with the Herbst appliance is that the occlusal plane rotated in a clockwise direction and the maxilla went back. So mandibular post-rotation is not so welcome in a class 2 malocclusion. And the lower incisor proclination, which is the side effects of the Herbst appliance, even if I didn't touch the lower incisor, is not so welcome, and it happened in this patient. What about normal growth? Is very favorable, very favorable. Mandible is longer and normal growth is favorable, but I don't see it. I don't see it. Profile still is a class 2. Of course, you will say it's not so bad, of course. I agree. It will improve very much if we let the BART grows. But profile is not a problem. Even if I don't see the improvement in the chin, in the mandible, even if I don't see a longer chin, because it is only a matter of 2-3 millimeters, despite the counterclockwise favorable growth, I don't see it. What I see is the displacement of the upper incisor to match back. What I see is a little bit of maxillary back displacement. But even more, what I see, what everybody sees, is not the profile, is the frontal appearance of the teeth. And once again, if you are in front of a class 2 with a retrognathic maxilla, mandible, and you correct it by pushing back the maxilla, of course, the smile is narrow and is not so beautiful. A narrow smile is a typical feature of the class 2 malocclusion, corrected orthodontically or orthopedically. So take home message, whatever you do, even if you use functional appliances, you will displace the maxilla back, you will get a narrow smile, whatever you do, extraction, non-extraction. These 3 patients are treated non-extraction, all. And even if growth is favorable, he is 22 years of age now. This is what we can do.